Thank you very much for the opportunity to present this work. So this really is, I want to emphasize how much this is a group effort, that the work that I'll be presenting. This is the collaborative effort with my various colleagues at Mass General, Biostatistics, Harvard Medical School, and the Harvard Chan School of Public Health. And so I'll be talking today specifically about kind of this challenge number 6 that Andrea laid out, which is the auxiliary variable dependent testing in observational studies of long COVID. I will be focusing actually a little bit more on the pediatric study in RECOVER, though there are, again, many of these principles apply both to the pediatric and the adult studies, as well as many other studies of long COVID that use related sampling techniques. So we've heard plenty about RECOVER today. Specifically, the RECOVER Pediatrics Observational Cohort includes children who are ages 0 to 25, those who do and do not have a history of SARS-CoV-2 infection across these 5 different age groups. And these participants are being followed for up to 4 years in kind of the first phase of RECOVER, and then for an additional up to 2 additional years after that in the next phase. And as part of so the way that RECOVER Pediatrics works, as Dr. Gross mentioned earlier today, participants enroll into the study. They complete remote surveys at the beginning, including surveys related to their history of COVID, health challenges, et cetera. And they also receive this TASO kit for remote biospecimen collection. But this is all done remotely for all of the participants who are enrolled into RECOVER Pediatrics. But the study tiering that happens within RECOVER Pediatrics is quite complicated. So here I have a figure showing how the green boxes for 10 different participants who are in RECOVER, they have a single remote visit that can occur any amount of time after infection for somebody who's infected, and then at any time for somebody who enrolls without a history of infection. And all of the visits after that are timed relative to when that first visit occurred. And these visits that are happening after enrollment is this tier 2 visit phase of the study, which is the longitudinal phase of the study. And there are in-person visits starting at 6 months after enrollment up to 48 months. And so you'll notice that not all participants are selected to be participating in tier 2. This is not just due to attrition. It's the fact that many infected participants, that there is a promotion algorithm that determines which participants are followed into the longitudinal phase of the pediatric study. And this decision is based on the likelihood of having long COVID at the tier 1 visit. So this figure here describes the study design of pediatrics, where we're selecting who is selected to participate in tier 2 of RECOVER Pediatrics. And this is based on this design that is meant to enrich the longitudinal cohort with those who are very likely to have long COVID. And so the first thing that's done is that a random sample of all infected participants are promoted to tier 2. So that's step 1 here, where participants are promoted regardless of how likely they are to have long COVID symptoms. And then in step 2, the tier 2 sample is enriched with participants who have a high or medium probability of having long COVID, as well as those who are acute infected, meaning participants who were enrolled in RECOVER very close to the time of their initial infection with COVID. And then finally, a random sample of uninfected participants are promoted to tier 2. So you can see that the tier 2 cohort is smaller than the tier 1 cohort, and these are the participants that we're having longitudinal data on. And so not only is RECOVER Pediatrics tier 2, this longitudinal phase, actually have repeated measures, but there also are a wide variety of tier 2, quote unquote, assessments that are occurring during these in-person visits. And I've just listed some of them here, which include measurement of vital signs, electrocardiograms, spirometry, et cetera, all of which are really critical for understanding the mechanisms behind long COVID. And in Andrea's presentation, she also showed the various assessments that are being done in the adult study, also intended to uncover the mechanisms of a long COVID in adults. And so I wanted to bring up again the network of biostatisticians for Recover. I've had the great opportunity to work with biostatisticians at many different groups across the country, and 4 of these nodes, so to speak, in the network are working on pediatric-related studies, answering questions such as these related to long COVID and sleep symptoms, dysautonomia, neurocognitive development, as well as whether long COVID can be diagnosed using standard laboratory assessments. The important thing is that 3 of 4 questions here are using data that's collected only in the longitudinal phase. And so they need methods that can deal with the fact that these assessments are only occurring in this select subsample of participants. And so when we're thinking about long COVID and these tier 2 test results, because of the sampling design that I described previously, some might refer to that as case cohort sampling, as well as selection bias affecting who's willing to participate in tier 2, a naive comparison of clinical outcomes between those with and without long COVID is very likely to be biased. We don't have a random, who's getting all of these tests is not random. It's driven by the symptoms that we're seeing in these participants, as well as participation bias in terms of who wants to participate in these studies. And so all of these really need to be taken into account in order for us to draw valid conclusions about the associations and understand the mechanisms that are underlying long COVID as they relate to many of these different tests that I'm talking about today. So I have this figure again here. I'm introducing just a very small amount of notation where we're looking at some exposure A, which might be long COVID status or LC status, some test result, which is determined, which I'm calling Y here, and then R representing promotion to tier 2, and then C being this sort of censoring mechanism indicating who is completing a tier 2 test. And so one approach to handle the sampling, the complex sampling that I've been talking about, is to use a sequence of inverse probability weights to proceed with estimation. And these inverse probability weights can account for multiple things at the same time. First, imbalance in the covariates between those who have long COVID and don't, sampling into tier 2, as well as completion of these tier 2 tests. And so in Recover Pediatrics, we do know the probabilities for number 2 here. So those are known, but we need to fit a couple of additional models. First, this propensity model in order to impose balance on covariates, as well as a model for this censoring mechanism. And so if we wanted to appeal to causal inference and try to estimate some sort of average treatment effect to quantify the difference in some assessment, some clinical assessment comparing those with and without long COVID, we could proceed in estimating this effect by multiplying each of our outcomes by this sequence of inverse probability weights. This is one valid approach that can be taken, but we can also appeal to semi-parametric theory where we can use a doubly robust approach where we also estimate a model for the outcome, which is the clinical assessment itself, and then use the efficient influence function in order to construct this doubly robust estimator of an average treatment effect. And so here, we're using this sort of modular approach where we are trying to define this influence function amongst people who have complete data, and then apply some weights to it to account for the complex sampling mechanism. And so we've been able to derive this one-step de-biased estimator that's allowing us to account for the very complex sampling framework. Bringing it back a little bit into the adult study. So the study design allowed varying entry time relative to date of the first infection, but many clinical assessments in Recover Adult. So in Recover Adult, everybody is followed longitudinally, but not everybody gets every test. And these tests are triggered by specific clinical findings. For example, the fibroscan, which is meant to measure the fibroids in the liver, is triggered by specific lab tests or abnormalities. And so if you have the trigger, you get offered the test, but if you don't have the trigger, there's still some non-zero probability that you're getting offered it. And also the sampling is repeated over time. And so colleagues on this project, led by Harrison Reeder, but also with our colleagues at the University of Utah, have been working on methods to deal with this even more complicated sampling scenario where, the sampling is repeated over time, where not everybody is getting the same assessments. And so whenever you're presented with, oh, we have this many people with long COVID and this many people without long COVID who did this clinical assessment, it's very, very important to pay attention to why it is that they got those tests and account for that when conducting your analysis. Okay, so just wanted to conclude here thanking our funding sources, as well as for all the participants in Recover that make all of these analyses possible so we can learn more about how to treat long COVID. Thanks everyone for your time.